we're going to have to move forward and move on to the next presentation, which is James Hurley from the University of Melbourne. And James is presenting on visualising and diagnosing spillover within randomised controlled trials using diagnostic test assessment methods in Stata. Welcome, James.
Thank you. Thank you for that introduction, and thank you for the invitation to talk today. And thank you for the organising committee. Last night, I'm honoured to be the warm-up act for Chuck Huber. Chuck suggested that he might be my warm-up act, but I said, no, let's stick to the schedule. By way of introduction, I'm a general physician in a hospital in Ballarat, which is near Melbourne. I'm also associated with the University of Melbourne, where I teach medical students. My day job is looking after patients, and my hobby is working out why pneumonia rates vary so much in one ICU to another. And my model for this is published rates of pneumonia in published studies in the literature, which will become clear. I am a general physician, so I don't actually work in the intensive care unit, but the origin for this, which I've been working on for at least the last 20 years, is I visit the ICU in a capacity of infection control. So the intensivists managing individual patients may not see that they have different rates of pneumonia in their ICU compared to comparable ICUs or non-comparable ICUs. So this is a patient I'm talking about who is being hit by a bus and comes into the intensive care unit. He doesn't have pneumonia when he comes into the intensive care unit, but will acquire it in between 5 to 20%, 5 to 40% of situations for individual patients. And that's the widely accepted expert range for the pneumonia incidence in the literature. It's important to remember that where the pneumonia comes from, some of it comes from the person's individual flora, but some of it comes from the intensive care unit. So if you ever are in this situation, look out for the patient in the next bed who looks like this. So a key thought here is if you did a study to prevent pneumonia, there are two types of study designs that you might use. You might have on the left-hand side in ICU number 1, the intervention groups in the same ICU as the control groups, and you would have concurrent controls. Or you could do a non-concurrent control design study where you have the intervention groups and the control groups in different ICUs separated by a brick wall. And also there are other ways there's a whole variety of ways to prevent pneumonia using antimicrobials, and these seem to be effective in a large number of controlled trials using concurrent controls. And there are non-antimicrobial based methods which are less effective. A key thought here is that if you reduce infection in adjacent patients, that might influence the control group rate of pneumonia, which would be the case for trials where you have patients that are concurrently in the same ICU versus wouldn't be an issue for patients that were non-concurrent. And this raises the issue of the stable unit treatment value assumption, SUTVA, which is a key requirement for inference from randomized concurrent controlled trials, which I have to say is rarely mentioned because it is so implicit. This is a summary of nearly 200 randomized concurrent controlled trials that I've pulled from the literature. All of these studies have come from Cochrane reviews, and the source of the data is in the reference list at the back. On the left, we have studies that use non-antimicrobial methods, and on the right, studies that used antimicrobial methods. I've sorted the studies by effect size order, and you can see at a glance, which people rarely do, I might add. They're often by first name author, which is pointless. with this sort, you can see at a glance that on the left, the non-antimicrobial prevention methods are slightly effective with an effect size of odds ratio 0.82 from 122 studies. On the right, the antimicrobial-based interventions have an effect size of odds ratio 0.39 from 68 studies. The summary point is so small there and so precise you can barely see it at the bottom, but it is in red. The simple point of this slide is to show that there are a few outliers, but really not many. And the measure for what might be an outlier is often the I-squared, which is a measure claimed as a measure of heterogeneity, but it's really a ratio of the variability within studies to the total variability which is within and between studies. And the I-squared here is 50% on the left and 72% on the right, which might suggest that there's really not much problem. But as will become apparent, there is a problem. So the thought here in developing, comparing infection rates across different publications in the literature, on the top left, we have one ICU with a control group in open color and an intervention group in a closed symbol. And these two control and intervention groups come from the same ICU. So in the top panel on the left, we have 12 randomized controlled trials. Each has one control and one intervention group, and there's been no intervention. They've been randomized and no intervention has occurred. The second panel down, there's been an intervention. It's slightly effective. The intervention groups have moved to the left relative to the yellow vertical bar, which is the low limit of pneumonia incidence by the expert range, which is 5%. The third panel down is where an intervention has been applied and it is effective. And there is much more movement of the intervention groups to the left. But you'll notice the control groups have not moved. The fourth panel is where there might be spillover, and preventing infection in the intervention group has spilled over to reduce the infection rate in the adjacent control groups in those ICUs. And so those control groups themselves have moved to the right, to the left, relative to that yellow line. And the fifth panel, same thing, but in this case, the spillover has caused an increase in pneumonia rate. So the control groups have moved to the right relative to that orange line, which is the upper limit of the expert range, which was 40%. And the bottom panel is the same thing, but the movement in control groups, some control groups have moved to the right, but some haven't. And so there's increased variability amongst the control groups and also amongst the intervention groups. That's the, I guess, driving hypothesis behind the research question to determine whether there might or might not be spillover between the intervention groups and the control groups. A few words about heterogeneity. There are a couple of measures, several measures for heterogeneity, and they're, I have to say, not good. The Q statistic and the I-squared statistic, they are both limited by the number of studies that you have, and they can be underpowered or overpowered for the detection of what might or might not be important heterogeneity. The I-squared statistic comes with measures that might be considered moderate, substantial, or considerable heterogeneity, but these are entirely arbitrary translations. The heterogeneity I'm going to emphasize is a visual interpretation, which will become clear. The Stata provides a command called the Labey plot, which has long been used to assess heterogeneity. On the left, we have the 120 studies of non-antimicrobial based prevention methods, and on the right, the 80 antimicrobial based prevention methods. This plot is a little bit busy. You don't want to interpret this plot if you've got a hangover. And there is a plot, there is a issue that this plot makes clear, but it's not immediately apparent. The scales on these are logit scales, which are on the x-axis for the control group and on the y-axis for the intervention group. The solid line y equals x is a line of no effect. And because we're studying a prevention intervention, the studies that have an intervention effect have moved to the bottom right-hand corner, slightly more so for the antimicrobial studies on the right than for the non-antimicrobial studies on the left. On the next slide, same plot, but I've now modified the scales, relabeled the scales on the X and Y axis to make it slightly easier to interpret. And I haven't put on the expert range, which is 5 to 40%, but you can do that in your mind. With that, you can now start to see that most of the non-antimicrobial groups, whether they're control or intervention, lie within the 5 to 40% range. But with the studies of antimicrobial-based prevention methods, the intervention groups are mostly within the range 5 to 40%, but the control groups are not so. And this will become even clearer when I move to an ellipse plot, which is what I would recommend you might want to do if you face this situation. So what is the Labey plot? The Labey plot dates back to the 1980s when meta-analysis really first took hold in the medical literature. And in the 1980s, there were a few randomized controlled trials to include in a meta-analysis. And so the Labey plot was a good way to explore the data, to see whether the relationship between the control and intervention groups was best summarized as a risk ratio or an odds ratio or a risk difference. If it was a risk ratio, you had a line that came through the origin. If it was an odd ratio, it was a curved line, as in the bottom right. Or if it was a risk difference, it was a line that was parallel to the y equals x line. And this plot enabled you to sort of try to work out what might be the best summary. There are other applications, the J-curve effect, but bottom line, this was a visual impression. And it was always a visual impression, which has, I have to say, the Labey plot is now in the 21st century has its limitations, where a lot of the studies that are in the literature are not good quality randomized controlled trials, and they may be subject to spillover. So the method that I used is a variation on the Labey plot, which is applied to the analysis of diagnostic tests. It's a summary receiver operating characteristic, and this is applied to diagnostic tests, which you have a group that has a disease negative, and a group that has a disease which is disease positive. And you want to set a breakpoint between those two populations to work out where to put your breakpoint. And you want to maximize the sensitivity and specificity, which is on the right-hand side. You want to test a breakpoint that will put that star in the top left column of that plot. And as you move your breakpoint by the blue arrow on the left, from left to right, making the test more specific, you move on the plot from right to left down that curved line, which is an odds ratio, to a summary point where there are various interpretations of the SROC curve, the Q star, which is a summary point, SROC curve, which is that curved line, because the interpretation of the diagnostic test is always as an odds ratio. But more recently, and the two references at the bottom of the slide are versions that produce an ellipse plot, which is the Matandi plot, which is a user-generated command, and MetaDTA, which has come out in the last couple of years, which is an even better version. And applying Matandi plot to the data that I produced for the 200 studies, This is the Laby plot that you saw before, but it now has these ellipse plots overlaid. You can see the summary point, the summary, which would be a diagnostic odds ratio, but here it's the effect size, is a red square. Surrounding that, you can barely see it, is the 95% confidence interval for that summary effect size. And that blue line is the 95% prediction interval, which is a much better way of predicting if you did another 100 versions of this test where 95% of them would lie. You can interpret this as you would for a diagnostic test with a true positive rate or a true negative rate, which is 1 minus the specificity. And these are interpretable as the average pneumonia rate amongst those studies. And on the left, the true positive rate is 18% in the control groups and the true negative rate is 21% in the control groups, 18% in the intervention groups. Whereas on the right, for the antimicrobial studies, the 68, and we have the same diagnostic, the same odds ratios equating to the effect size that were generated in the meta-analysis forest plots that I showed before. These effect sizes are comparable. On the right, the true positive rate, the pneumonia rate in the intervention group is 16%, but the control group rate is 34%. But you can see at a glance that we have on the right a beached whale. It should look like an ellipse, but the distribution of the control groups has been shifted to the right, and we have a lot of control groups that are greater than 40%, which you wouldn't otherwise notice if you just looked at a meta-analysis straight up. And as most people do, focus on the summary effect size without looking at the studies within. The codes I've placed at the bottom. And I believe this equates to a spillover of pneumonia occurring into the control group in patients who are in concurrent controlled trials, which is not something that's usually seen. In herd effects, you would be familiar with herd effects from vaccinations. So if you give a population an influenza vaccine as a controlled trial, the reducing influenza in the control group, in the intervention group, also reduces influenza in the control group as a positive effect, as a positive beneficial spillover. Here it's with the antimicrobial intervention, it's a harmful spillover causing an increase in pneumonia rate. So what would happen if we had a spillover that was beneficial? I've pulled out studies where in these Cochrane reviews, the control group actually also received antibiotics as all members of the control group, so that all received protocol by protocol antibiotics. Why you would do that, I'm not sure, but both the control group and the intervention group received antibiotics to prevent pneumonia. So that middle plot is it's not a beached whale, it's sort of a beached tadpole. And it's been squashed in both directions from what should be the ellipse. Small number of studies, but that is, I believe, what the effect would be if there was spillover that was beneficial to the control group. So in conclusion, the stable unit treatment variant assumption, there is no formal statistical test. I believe it is a visual impression, and it is a belief that you have in the data that spillover may or may not exist. The SROC, which has previously been applied to the evaluation of diagnostic tests, enables a visual test, being the shape of the 95% prediction interval, and that shape of that prediction interval is a clue to the presence of spillover. Whilst this SROC is entirely analogous to the Laby plot, I think it has a lot of improvements in this context. And this work keeps going. Any questions? The question was, can study quality be a factor in the interpretation of these plots? Look, the whole question of study quality, if you do a Cochrane review, you do measure study, you evaluate study quality, and there are set criteria for how you do it. Strangely, spillover is not one of the criteria. And because in most instances, randomized controlled trials, spillover is not an issue. It's only when you're dealing with an endpoint which is contagious and might influence the control group with a concurrent intervention group. So I don't know if that answers your question, but study quality, as reported in the Cochrane reviews, does not come into this.
Just like up there, James, because we're right on time. You've been very efficient and finished right on time and brought us back to task. So thanks very much, James.